everybody. Thanks, Cindy. My thanks to Elevation for having me guys with you. Yeah, I mean, if you go back and watch the original CCRP videos on Shockwave, it was all electrohydraulic. And it's actually my hand that Dr. Millis was demonstrating it on, and I was not sedated. So that was my first experience with Shockwave, was 2008. And needless to say, the times have changed. Who on this group, and feel free to turn on your videos, we can be, I want this to be honestly whatever you guys want it. I don't need to sit here and lecture at all. Who either raise your hands or pop on your video and raise your hand, or electronically, wave or whatever Zoom does. Who has a Shockwave in their clinic now? I see Catherine's, right? Julie's got one, right? So you guys have a PZO system. Did anybody have a different system before at all? Any? Catherine, yes? You're muted. That's okay. I'll believe you. It's okay. And the thing was like, how often did you really use it? Because if you're not, otherwise you have to sedate them to do it. The owners have to sign off on that. To me, they always kind of went home being more lame than they were coming in. And I'm like, trust me, they're going to look better a couple of weeks from now. Right?
Yeah. Yeah.
And to be honest, I'm trying to look at everybody's names and stuff on here. Who are doctors? Who are PTs? Who are vet techs? Doctors raise their hands or give me some sort of clue. All right, Julie, okay. Catherine?
Vet tech.
Vet tech.
Yeah, I'm a doctor.
Okay, hey, all right, so we're trying to watch, so with other systems, it was always like, okay, we have to get you in, we have to get an anesthesia person in, we have to sedate this dog, and we got some good results. That's the best technology we had. And then when the piezoelectric system came around, I was like, cool, I'm pulled in 1,000 different directions, and my tech do all of this, and they always have an assistant with them, just so nobody gets hurt and keeping tabs on everything. But it's all done outpatient and they look better. So when this kind of came around, Cindy was kind enough to get me a demo unit, and I was seeing some stuff from teaching the CCRP course when it was coming around, that I was like, okay, this I know I want. I just had to figure out where I was going to be with my career. Because to me, I don't know if you guys can see, my team is awesome. They brought in mine just to have around in case we need to talk about anything in particular. But I love this machine because I can make myself feel better. And we have now had these a little over a year, Cindy, like 15 months. We've paid off both. We just bought linear probes for both of our machines yesterday. Highly recommend those. They're a blast. Bad pun intended. There's a whole hour of puns. Cindy knows this. They're all unintentional puns until I realize what they are usually. But we just got the linear probe. And I think in 15 months of having these, almost 18 months, I can count on 2 hands the number of patients I've directly treated awake, because I don't see rehab visits anymore. Now, your clinic practices may be set up differently, but if you can optimize your time, your technicians can utilize this, where we as doctors can kind of come in and be good diagnosticians and be like, yeah, let's do this. Hey, tweak this one a little bit, and then have the tech treat it. The PTs, that's a huge asset. So that was my biggest step there. Where I use this the most, and I'll be honest, I say is on my patients that we're doing sedated procedures on. Okay, so if I'm injecting PRP and something like that into a shoulder because we've got a biceps tendinopathy and a supraspinatus tendinopathy, and we're treating with PZO at that same time because we're pairing that. So we're attacking the supraspinatus, which is extra articular, with this, and we're attacking inside the joint with the PRP and this. So we're getting a multimodal approach. When we do those, what we honestly have found is that we have a divide and conquer set up with my team. And so while I'm injecting one dog, they're sedating and they're putting a catheter in the other one. And while they put the catheter in that one, they're then treating the shoulder with the dog awake. And then all I have to do is follow up. We sedate them, right? Basically, it's fentanyl propofol, and I'm in and out of the joint, or my intern is in and out of the joint with a needle injecting. So we've cut our anesthesia time by probably 80% compared to when we used to use an electrohydraulic system. So it's made a huge asset for us, because then they wake up from fentanyl propofol, they go home 3 hours later, and the owners are like, wait, what voodoo did you do? Because the dog just looks better. So that was our biggest asset to utilize this. And as much as we love having it on our team as a device, it is not in my hands. It really is a device. I found it to be the best effective thing for my team to be able to utilize it, because instead of doing like 10 or 15 treatments a month on electrohydraulics, we're doing like between 8 and 12 patients a day with piezoelectrics. So that's what allowed us to pay off the machines in 12 months too. Was to really work on that, was just to figure out where we can use it. And the answer was we can use it on so many more things. And I went back and looked, it was fun because when we switched over, we had a bunch of dogs that cardiology gave me the don't you dare sedate rule. You ever see that from your cardiology group? Anesthesia would result most likely in death. Like my cardiology group is very blunt, and I really appreciate them about that. But I was like, okay, how are we going to make this poor geriatric dog better? Because it still hurts. And those are the ones we went on our train wreck ones first and used this on the demo unit. And it was that and its ability for us to fix the metacarpophalangeal joint of my boss who does our hip replacements. We fixed her thumb, and she looked at me and she goes, I don't care if you never use this on a dog or a cat. I want this machine in my clinic so I can fix my hand whenever I want. So that was kind of my background here at VSC and VSCR on how we got started with it, and how we're utilizing it. Does that make sense to everybody? I know my practice model is going to be a lot different than a lot of others, but how can I help you guys? What questions fall into that area? And I apologize, is it Dean or Dan? Your box lit up for a second, but we didn't hear you.
Deanne, I think I just accidentally unmuted myself, so I didn't want to be loud. I guess my question for you is, do you start with settings similar to what's in the book, or do you have your own subset of settings that you prefer to start with patients? Like, do you go high, low, depend on the joints, the dog, that kind of a thing?
That's an excellent question. And I think if you polled my 3 CCRP techs and then also polled like my intern and stuff, you'd probably get a couple of different answers. I know you would. It was funny. I used to think that was more is better. So we used to wallop a lot of stuff with things. Because I was like, well, we should use like the intensity goes up to like 10. We should be using 10, right? Like if they can tolerate it, it's good. And then Cindy came over when she demoed it, and we're going to the CCRP courses, and she showed me this magic of like dropping your intensity to, I don't know if you can see this, it's like 0.3, and watching the really grumpy animal just sit there. And I'm like, sure, Cindy, right, this is going to really do something. I'm like, this is tiny. And in Cindy's hands especially, then you watch the decrepit dog. It was down at the CCRP course in Raleigh, and this decrepit dog just gets up and walks away. And I was like, okay, I need to use less intensity. So I think that is a little bit of an artistic understanding too, that you have to, like, if you know that you've exactly nailed your pad size and exactly nailed what you're treating in what position, I think you can really be extremely focused, like beyond like pinpoint precision. But when you're first getting started with them, you still, the nice is you have such a safety range with it and that response. So that's why, like, when we do these, we don't do them solo. The assistant is up at the front or near the head, right? If we're, no matter what we're treating, and we're watching for them, like, are they licking their lips? Are they anxious? Did they fall asleep? Like, I always love the ones that, like, are falling asleep and you still hear the machine going, and I'm like, that's a good day. So I probably utilize, I think when you're starting, I probably would stick to the guides and the settings, but then start to get the feedback a little bit. It's somewhat patient dependent, where if I can get in and we can treat it at, let's say, 6, but then I'll be like, all right, well, let's drop it down, and you can still watch them. That's still the nice point is too, is I may treat them for, like, we've done this, the CRP courses too, where I'm like, treat them for like 500 pulses instead of 1,000 or 2,000, and let them get up and walk around and see what they do. Do they look a little bit better? Or if they're still lying down, like, just repeat your assessment. So whether that's stretching the shoulder, doing bicep stretch, like, yes, there's a large degree of subjectivity to it, but what do you see? And you're like, gee, after 500, this should have been a little bit better. Was I not on the right point? Or do I need a little higher? Or can I actually go, I got some good results. Can I go down from an intensity of 6 to, let's say, 3, and do that same 500 pulses and then reassess it again? So I think when we've used it more, it's been still treating 2,000 pulses per time, but we've probably broken it down a little bit early on to figure out how to tailor it for each patient.
Awesome, thank you.
Yeah. Does anybody else have? I'll talk about other stuff, but it would, where is folks using it? Like, are using it for only shoulders, Achilles, joints? What, at least on the snow cone. We can get into the leg second, but where's everybody using it? Because I'm always interested to hear this too.
For me, I use it primarily, like, my first go-to is elbows, because I think elbows suck no matter what. So I like it for my elbows and my hips. I like it for backs a lot as well. If I have dogs who have a lot of back pain, triggers, things like that, we do a lot of scanning on that. But I've kind of used it all over. A lot of times I'll start with laser if they have multiple areas, and then I'll switch to piezo for the ones that aren't quite responding to the laser treatment.
And do you guys have, because I see that Catherine's got her linear probe. Do you guys have a linear probe?
No, we just have the regular.
So if you're scanning a lot, like, say you're using laser first, 100%, you have it, utilize it. But sometimes kind of the linear probe, to be able to scan through an area and then watch them relax a little bit. I feel like I get a more consistent and more quicker feedback that I'm in the right or the wrong spot with a linear probe than I do with a laser. At least my older experience with lasers. The new stuff coming out, I think, is a little bit different. But that's kind of where I've seen it for the most part.
And I don't do laser and piezo generally in the same day. I just say, like, if I have a dog who's got elbows, hips, shoulders, back, and they need all of those areas treated, I may start laser on those dogs. And then if I'm not getting the response, like I'm still getting hip pain, then I'm going to add piezo for the hips instead. Oh. But it's interesting that the linear gives you immediate feedback. And I like the idea that you recheck after 500 pulses to see how it is.
Yeah. You just see, I kind of sit there, we always have, and usually I have it in my pocket, but I always have my tape measure, right? Because I'm always measuring, or I have a goniometer. So I'm always, like, measuring muscle mass. And so I'm like, all right, I'm trying to get to this. Like, in theory, it's the biceps, which is the dead of the shoulder. And I'm like, well, what is that? So I'm like, okay, it's that centimeters. And, it's 5 centimeters. I'm like, well, if I have to get to 5, I want to try to get to the middle of it most likely. And that's where I'm just sitting there doing math with the sound heads to go, where can I be, how fairly certain, with 90-95% certainty, can I drop into exactly where I want to be? Because if I take that aspect, and try this on yourselves too. If you have something that doesn't hurt, okay, no matter how much you turn it up, right? If you're not on something uncomfortable, this doesn't do anything that we know of. It'd be really cool if there's like, they're starting to look at laser light about like preemptive stuff, like for sports training. It'd be interesting to see if you could do the same thing with piezoelectric. But for right now, if you're on a non-painful area with piezo, you don't feel anything. So trying it to see like, hey, I know this area hurts on me, like trying to figure out like which pad size is the wrong one is almost as much of a fun game on yourselves, and trying it to like scan through and be like, okay, this didn't do anything, but I know it's because I don't hurt there. And trying to see those has been a neat way to kind of go through those. Especially you guys all have experience with them too. It's fun watching the folks at the CCRP labs because they've never even felt this in their hands before, and they're like, oh, this is going to hurt because electrohydraulic hurts no matter what, with all due respect. And then they're like, wait, this didn't hurt. Like what the heck happened?
So I'm doing my first CCRP case, and it's conservative management of a conformation type Bernese Mountain Dog. And she is huge in my book. And the breeder keeps saying she's tiny. And I'm like, sorry, but she's huge for me. And I'm treating her. She did blow her cruciate. And
no,
but finally the lady, I was doing all my goniometry, trying to get it pretty close. And she said, so does this change the range of motion? And we did actually take the time to remeasure after I treated the dog 2 days ago. And there was 5 degrees difference in a very different end field, from 750 pulses lateral, medial, and 500 on the patella tendon. And I just think sometimes when we're doing it, we don't take the time to check that before and after. I know we don't because we're all in a hurry, right? But
if you can, like, I just walk them out. Like, I'm still thankful we're curbside to a little bit of a degree, because I actually we go up with them. I watch them walk down a little bit, or I watch them walk out. My rehab practitioners all do that. They go up and they talk to them, and they're like, so you get those few seconds or minute of them walking, and you're seeing that gives your brain some info on where, like, yes, it's a TPLO recovery, fine. It's what we all see billions of. But they walk in, you watch them walk in, and you're like, okay, it's a left TPLO and your right traps are shot today. Like, what did you do stupid? Like, that's the first thing you're gonna go after, just watching them walk in. And so there's some ways to make up that time. I think if you just watch them move for just a few seconds.
So I don't have a linear probe. How is it different?
So you're hitting a much higher volume of tissue, and you don't have to be nearly as accurate in your driving. It is a little bit bigger. So you do, in our opinion, you need a pinpoint therapy source to do the real small dogs medially and stuff. But this is an amazing add-on for backs, for hip muscles, for neck muscles. Oh my, like, it's giving us a real easy way to do our myofascial work as technicians who aren't going to dry needle.
Yeah.
So that's pretty key.
That's where I knew about it, and it was on my radar, and I was like, okay, how are we going to do it? And then as Michelle Broadhurst and I teach a course on myofascial trigger points. And Michelle's, if you don't know her, she's a fantastic chiropractor, CCRP from South Africa, who now lives in the States. And in some states, yes, veterinarians, we can dry needle. PTs depends on the state. DCs depends on the state. But technicians, which is dumb because you guys hit veins for us, right? It's really, really dumb. But you can't, for whatever reason, dry needle, to my knowledge, in any state in the US as a technician.
No. Yeah.
Right.
You can't. No.
Right. So then your choices with that, right? If you've identified a trigger point, you can use your own hands, which we all appreciate, but if you're seeing 1,000 patients. We don't want your hands to break down. Laser's a good tool on some of these too. If you have it, you can it's almost like doing laser acupuncture settings and just delivering a little bit of joules to it. But again, for small once-off trigger points, sure. For small once-off trigger points, sure. But if the whole dog is a walking mess, like think about your DM dog, right? Your DM shepherd with bad elbows, right? That dog's shoulders and spinal muscles are a disaster. And you could either sit there going, you could spend 40 minutes massaging that poor dog out and pressure and trigger pointing everything, and then have no treatment time left to do anything else with that poor dog. Or you can hit them with the linear probe in about 7 minutes and then go do stuff with them. Sound about right, Cindy? So we started doing that. So Michelle and I now use that because Elevation's been very kind enough to help sponsor the CSMP course, the myofascial course, because now what we do is we just put the physio in the hands of the technicians. You guys learn how to diagnose all the trigger points, and now you can directly treat them, which still keeps the doctors doing doctor things.
We are all trying hard to figure out our best PRP shockwave protocols.
So no, this is totally fair. I actually who I want to talk to are some of the equine vets, and because I don't want to talk to some of the human sports med folks, because they've all used different ones. Some of them are using Carl Storrs makes a shockwave device. There's obviously other electrohydraulics. There's different systems, and I don't know honestly if anybody's done a deep dive, double-blind, peer-reviewed comparison and understanding, or has done, and I know because Carrie's there with her PhD, I see you, Dr. Adrian, right? Has anybody done even just a in tissue, right? Like not a cadaveric, but like an in vitro, like has anybody looked at like what shock waves do if we throw PRP on top of it, right? You can't do it in a Petri dish. So where I've been most comfortable is we use the physio on the injected joint prior to injection.
Oh,
And then I put in my product.
Why?
Okay.
why, yeah.
Because then I know I can treat the joint and calm it down, and then I'm using the injectable material to extend that. What I have to double check is, depending on what sound waves and generation is, are the sound waves, and I think it 100% depends on the therapy source and the way we're generating a sound wave. But some of these sound waves in theory would be destructive to platelets. And if they're destructive and the alpha granules degranulate too soon, or you change that, are you then essentially wasting the PRP?
Right.
Like when we were at VOSM, Sherman Knapp said heck to the no about shockwaving on top of stem cells, because there was one paper looking at electrohydraulic, and that's all we had at the time, on top of stem cells in vitro, and they exploded. So we were going to then waste $6,000 on that. You put the stem cells in and then shockwaved on top. In theory, you're wasting $6,000 worth of stem cells for that dog. So that's my only experience. But I'm open to other. What's everybody else do? There's my logic. I'm like, let me put one in and then put a second one in, and they can be synergistic together. But I'm not trying to modify them. I'm just putting them in separately into the drawer.
I think the black and white is equine versus canine.
And I think they're going to be different too. So what's equine doing? What's anybody hearing?
Equine always injects PRP and shockwaves immediately. Period. Based on.
But here's my question.
Based on.
Is it PRP or is it, because what gets lumped as equine PRP is not always PRP. It's not always true platelets. So if they're going through and they're doing it through glass beads and they're activating the white cells instead, that is a whole different mechanism of action. So we have to clarify with the equine folks what exactly they're doing.
Yeah, and some are doing what you're saying, which is what we call prostride, and others do PRP. And yeah, again, it's a black hole. you know, I do agree it's a black hole, and we just have to play with it and figure it out for sure.
I like the two together. So what I'm doing a lot is, and we're going to write it up, is we use the Arthrex ACP system, not their Angel system, their ACP stuff. So it's autologous conditioned plasma. I personally, when I inject, I always inject something that is viscous. So I don't put in ACP alone, PRP. I always put in with hyaluronic acid so we get instant viscosity, because the viscosity of an arthritic joint or tendinopathy joint is already low. So to my logic is, why am I putting in an aqueous ACP PRP and dropping the viscosity further? There's papers showing you can combine PRP with HA, and they're not deleterious. So combine the two, get the viscosity from the HA. But since most of those, like I'm looking specifically at shoulders, so they don't have a ton of synovitis. They don't really have osteoarthritis. They're a tendinopathy for the most part when I'm catching them early. So they have a biceps tendinopathy on the sheath with a little bit of synovitis in the joint, and then they have a supraspinatus tendinopathy outside the joint. So what we're doing is we're doing Pizio for the supraspinatus and the shoulder joint, then sedating them, and then injecting PRP and HA. Now, there's papers that looked at PRP alone. Wendy Brooks put one out years ago. PRP alone one time worked in 40 for supraspinatus tendinopathy. They were putting it intralesional into the tendon. It only worked in 40% of patients for up to 30 days. Kristen Kirkby-Shaw and a group looked at electrohydraulic shockwave for repeating it twice, 3 weeks apart, for supraspinatus and biceps tendinopathy. And if you treated them once, it only worked for 50% of the time. If you did it twice, 3 weeks apart, it worked 67% of the time. And I think if you did it, there's a separate paper that if you did it 3 times, 3 weeks apart, it worked in 75% of the time. Nobody's ever looked at it as published, as far as I know, with piezoelectric. So my shoulder protocol is piezoelectric to treat the supraspinatus tendinopathy and the shoulder joint, combine, and then at that same visit, sedate them, putting PRP and HA. And then when I do that, we do that 3 treatments, 3 weeks apart, and we're reassessing. And so far, that has a 92% success rate. And that paper will come out later this year once I have enough cases. And even if it stays above 85, I'm happy. So I'm being careful when I'm putting them in, but I'm still using a multimodal approach. Anybody else? Now we opened up a rabbit hole. Let's go.
So what are you doing in between then? Those 3 weeks?
In between those 3. So the hard part with that is they're not on bed rest. They're not on maximal runaround craziness. They're all getting a home exercise program for passive range of motion, stretching, weight bearing, weight shifting, and they're on progressive leash walks up to 15 to 20 minutes TID in between sessions. Most of these, my patient population right now is not agility dogs. It's not sporting dogs. I have 80% pets, 20% working canine, as in working canines that all wear badges. So I have a very different subset. I don't see I've seen 3 border collies in 3 years. Okay. So we're keeping them active. And then after those 3 treatments, then they'll go into more formal rehab. I would probably do formal rehab in between those if I could. We just need more techs and more rehab spots.
So are these?
But in between, they're off their NSAIDs because I don't use NSAIDs for 2 weeks after PRP. So they're off their NSAIDs entirely. They may be on gabapentin. They may be on an electromagnetic field device at home in between.
So
But they're
getting a lot.
Huh?
They're getting a lot.
They're getting
They're getting
right, but they've already come in on all that and they're still dead sore. So the treatments are to really get them over that hump.
so so you don't start with this immediately off the bat. You said they're coming in for rehab, they're not really responding. Then you start with PRP and shockwave.
No, so they come in, they've been in other rehab facilities in
Okay.
the area, they've been to
Yeah.
other places. Then they come into me, so now I'm the third opinion usually. So
Right.
then we're either MRIing them, because here's a fun part for you, Carrie. 90% of what I see is undiagnosed and has never had images.
I believe
Okay.
that because they've gone from GP to GP to GP and they can't figure it out. So I think the other thing that and this is what I want to chat more with Cindy today is to be able to, are these just biceps supraspinatus, MSI, blah, blah, blah. Like, we've got to be able to try to categorize these at some point. In addition, are they mild, moderate, severe? And I think we are all missing the mark on all of this. To be perfectly blunt, we've got to figure this out.
And that's the thing. So I've got a client, like I said, I don't have the patient population they're not border collies, they're not, and I'm looking for medial shoulder instability and I'm not finding it. So to me, what I'm predominantly seeing on my exam is sagittal plane distortion movements. Okay, so trouble with extension, pain on bicep stretch. I'm not getting issues with abduction awake. Okay. We're imaging them. Some of them, the good news, some of them have at least had plain films. Some of them have had osteosarcs or synovial cell sarcs that have not been diagnosed, and I've been the third opinion. Okay, so those we take out of that study, right? Those are not getting that. Those are different, but they're getting lumped in as shoulder or soft tissue. So then I'm figuring, when they come to me and I'm like, all right, sagittal plane issues, we're then going, I can either MRI them, but I can't do that on site, so I can't treat them at the same time. So I can send them somewhere for MR, and then I have to bring them back to treat them. And our MR facility has been backed up until we're literally, if I'm in a basement, we're actually installing, I'll have an MRI by hopefully 4th of July, if not Labor Day. I'll have my own MRI right upstairs. So then I'll MR them all.
Ultrasound? You're doing MR over.
So the facility we work with here in Northern Virginia, my imaging team that I refer to can nail shoulders on MR, and they're really good at it. So I could do that. What I had was, when they were backed up, I was CTing them, because I try to catch it on CT and categorize it. I can CT MSK ultrasound it, because to me that was easier to do that and then treat them under that same sedation, versus, because to me, I prefer to get CT over plain films any day of the week. And when we looked at it here, where if you get lateral and AP of the shoulder, lateral and AP of the other shoulder for comparison, under sedation with a radiologist report, versus a CT of those shoulders, and they'll give me elbows in that all the way down with that same radiologist report, the difference in cost is $150. So I get the CT because I get double the images, double the info for the same price, and then I'll MSK ultrasound them, or I have an Arthrex nanoscope. So if I don't see it and those are much less likely, but if I'm not happy with what I see on MSK, I can pop in the nanoscope and look around. I get even more images and categorize them as mild, moderate, or severe as well, and then I can treat them. But most of what I'm seeing is supraspinatus and biceps together.
Right.
I'm not seeing sole biceps. I'm not seeing sole supras, but I'm not seeing MSIs.
Yeah. So if you had your druthers, would you choose MR, CT, or ultrasound for diagnostics?
I'd love to do a side-by-side comparison, because I think I have a bias, but I'm actually happier with My clients are happier when I do CT and ultrasound because they know they're treating under the same sedation and they're getting better that day.
I have to say hi to Dr. Miller. Okay, sorry.
My client's preference is CT MSK because we can also not only be diagnosing, but we're treating on the same day.
Okay, so you use the ultrasound for
that-
detection purposes, not for
So
diagnosis.
that's my client's preference. We've been so backed up during the pandemic that I've had to do that anyway because it was harder to get in for MR. When I have MR upstairs, I'll revisit this. But to be honest, CT plus MSK ultrasound is still $700 less than an MRI.
Right.
So
why not just
so-
MSK? Why not?
So my
Just
preference
why
then
instead of
would
paying
probably
for the
be, it depends though. So I've been doing CT MSK because then with MSK I get dynamic, right? I can appreciate dynamized motions on MSK ultrasound that I can't appreciate on MR. So that's probably my go-to. But if you look at what the human gold standard is, it's MR. So if we're trying to publish a paper, I'm trying to see where reviewer 2 is already going to whine about it, is why MRI. Now, the other thing is that a couple of these dogs that I have seen when I've been the 4th or 5th opinion, most of them have actually been humans. Well, they've all been humans. They've been either human human doctors or have had their own shoulder injuries and have just mandated that they wanted an MRI.
That's because insurance.
I
don't know that we're
No. Well, insurance pays for it on the human side, but we're in Fairfax and Loudoun County, which are the highest 2 household income averages in the country.
Well,
we outrank Orange County.
No.
So my clients are all driving. They're just like, well, gold standard is MR. And I'm like, okay, fine. And I love it because I at least have a reliable MR to give me that.
So that you're lucky in that you have all this awesome equipment.
Exactly.
But let's take this back to my average PT
Reality.
rehab practice where we're just getting, let's say, Lisa Mason, Heather Owen, we're just getting them really comfortable with MSK ultrasound. Can they get, and is there a diagnostic from MSK ultrasound? Do you feel it's legit?
Oh, 100%.
So
I mean, there's papers showing it's 85 to 90% accurate. So
I don't know that we need, CT MR. Would it, maybe it's gold standard in human, but I question the reality of that in vet med for diagnostics.
The thing about MSK is you're focused like this, right?
I like it.
You're focused. And you will miss stuff. Like I've had stuff that another practice in the area did an MSK ultrasound on, and they never took plain films and never CT'd. And they sent the dog to me because somebody had done an MSK ultrasound, but they're like, oh yeah, but we don't have PRP or shockwave. So go see Brunke so he can treat it. And I looked at the MSK ultrasound images and I'm like, this is boring. This doesn't fit. And I felt the dog and the dog screamed on scapular palpation because the dog had a scapular osteosarcoma that everybody had missed for 6 months.
Yeah, I mean, those are the
So
the
to me,
right? I think
so to me, if you're in fundamental, you've got this, how do you diagnose it? Either you, personal medical opinion here, right? You have to get scapular, shoulder, humerus, elbow radiographs with orthogonal views to confirm you don't have a global issue, and use MSK ultrasound as your soft tissue diagnosis, right? To see the tendinopathy on ultrasound 100%, but you have to rule out the global, or CT and MSK ultrasound, because that would be, but if you're going to, I wouldn't do just MSK ultrasound unless you have really good films recently, because I get burned and I don't want anybody here to ever have that. If we can all avoid, we're all going to have them, but I'm trying to minimize that damage control.
No, that's awesome. As we were saying, or we send them off for their diagnostics and get them diagnosed, which
100%.
which is what I think we would all rather do, but in some of our economies and lifestyle, it's just not an option.
No, but if you get good quality, get good quality, to me, sedated always, because you get better positioning if they hurt, right? Get good quality sedated rads and an MSK ultrasound, you're going to catch 80 to 85% of what's going on, right? That's perfect. You start treating it. If it gets better, you're on the right path. If it doesn't get better,
then you got to stop.
phone a friend,
Wow.
right? Then but those are the outliers. But the hard part is my world is so many, the outliers are my commons. So I try to just I have a narrower margin of error.
For
It's a
sure.
good one though. We got to find a, we
we'll
could play with that all day. But because the nice part is too, like some days, because my radiologist is in the office next door, and I'm really fairly comfortable reading CT. We'll CT those, and I'm like, yeah, I can see the tendinopathy from here, even on like there's enough change, it's severe enough. Like, do we have to MSK ultrasound? I still do, because I like to, because then I can follow up the images later, and I don't have to re-CT it to understand if it's having a flare.
Yep.
Plus, CT doesn't tell me if the biceps is torn. I had one that I was like, it was funny. I was like, it showed up blatantly. It was unilateral lameness. It showed up blatantly on CT. And my tech was like, you still going to ultrasound this? I'm like, yeah, I'm OCD for a reason. And I don't have it in my room here with me, but I have a portable ultrasound that plugs into an iPhone. So I don't have a big giant unit. I have one that can plug into an iPhone or an iPad. And I threw the probe on there, and the dog was painful on bicep stretch awake, and they positioned it for CT, and then I feel him afterwards, and I feel it again. It's got a really weird, like not the best end feel, and I throw the ultrasound probe on it, and that biceps is hanging on by 20%. And so what I actually did with that, which was really cool, because I'm a nerd and this is what I do, is I called the owner and I said, yes, it is a biceps tendinopathy. The bad news is it's hanging on by a thread and we need to release it. It ain't going to come back. The good news is if I can give them a little more anesthesia, I can do, and I've done ultrasound guided or scope guided biceps releases with literally an 18 gauge needle. You don't need a big fancy thing. And I went in and released the rest of that biceps. We charged them appropriately for it, but they didn't have to wake up and go through a $3,000 arthroscopy with the surgery department a month or two later. So we could still make the dog better on the spot. And we still injected it and we still PZO'd it because the capsulitis was raging. And then the poor dog felt better. So we took away the mechanics with the biceps release and made the whole joint feel better with everything else. Happy to see weird stuff. And I tell my intern, we walk away some days and she's like, how many of those have you seen before in your career? I'm like, this was the second. I'm like I have to improv about 80% of what I treat some days because that happens. But that's the fun part for me. But you can find common ones. Get good films, get a good MSK ultrasound, see it in dynamic motion. I love MSK, right? MSK, it's cheap. You always should image the other joint for comparison. And I always do that one first, and you can really see it. And most of my MSK, if I'm not CTing, MSK is awake. Like they just lay down, we shave it, we ultrasound, it doesn't hurt. We only sedate if I have to inject the joint. If I have to throw a needle through something, then they're getting drugs. And a lot more than just GABA and Traz. Like I'm not playing around. What's everybody, I don't want to get on a soapbox with that one. So does anybody have questions about that? I can cover it in more detail or less, or is there a different topic somebody wants to bring up?
So with your shoulder dogs, how many of them have elbow issues?
Well, that's an excellent question. I have elbow dogs that have secondary shoulder issues. So we treat the primary elbow. I very rarely have dogs that have primary shoulder pain that have secondary elbow pain, if that makes sense.
Okay.
But most of my true shoulder dogs, probably 4 out of 5 are shoulder only.
Okay.
Okay, 1 out of 5 will be shoulder secondary to bad elbows. But most of what I see as my shoulders are actually the ones that, let me back that up. The ones I'm imaging and injecting are primary shoulders. My technicians see all my train wreck elbow cases that have secondary shoulder tendinopathy. And that's why I got the linear probe yesterday.
Okay.
Okay, because then they can treat the whole area. So it totally, elbow dysplasia, elbow away is always going to cause a secondary shoulder tendinopathy.
Okay.
And you have to manage those.
Yeah.
Okay, but
Yeah.
most 90% of those, if you make the elbow feel better, then the shoulder is going to follow, and you don't have to do advanced imaging and do all sorts of upregulated interventions
Right.
for the shoulder
Right.
joint or shoulder area itself. But if you don't treat the elbow, like if you're struggling and you're treating a shoulder and you're like, the shoulder's not getting better, the shoulder's not getting better, trust me, there's an elbow behind it. There's something you're missing.
Yeah.
I had that. I felt really bad. I was the 5th opinion between 2 GPs, a rehab department, and a specialist. And the dog had been treated for 2 years, and it was a 8-year-old golden retriever-ish thing that they were treating as a primary shoulder for 2 years, and had imaged the shoulder, and they'd gotten elbow rads at the time, and the dog's elbow looked really clean. And the dog came to me, had the subtlest of elbow effusion and the subtlest of like just blink winced, like didn't even lick its lips, just was like you hyperextended its elbow and it blinked. And that was all it did on that one side, but it was off by 2 centimeters between its 2 front legs. We CT'd that dog instead, and that dog had an in situ jump down elbow fragment. And we went in, got it scoped out, and that dog was sound 3 weeks post scope. That I felt good to make the dog feel better. The level of frustration, the owner was finally better that the dog was better. I felt bad, but that was the weird of the weird of the weird. But if they're not getting better, keep looking.
So when you're doing the treatment before your PRP, how intense are you going and how many pulses are you giving?
Beautiful question. My team wrote down their things because they knew they're like, what are you talking about? I'm like, oh yeah, I forgot to tell them I was doing this. So usually it is a frequency of 6, an intensity of about 3 to 6, and it's about 2,000 pulses per shoulder. So we're around 3 to 6, but we're doing it all awake. Yeah. And it depends on what the dog, like if the dog is like, nope, we go down, but we don't really go above 6 on those. And it depends on how severe they are. Like, and that's probably more my, like, again, like I said, my techs see mild shoulder issues secondary to elbows. Those never come to me. So I only see moderate to severe tendinopathies, to be honest. And so within that, like they're mild to me. I'm like, oh, they're sore, but they're there. So we need a little bit more energy with most of those. That's what we found on those cases. But my techs are using it so much lower. It's just I get the stuff that's been festering and painful and not responding.
Okay.
Cindy, you're muted. Now
So
you're not.
Kathy, we do have both Kirsty and Lynn, his techs, doing one of these. So that would be interesting because they do see the more normal cases, and they're the ones running the machine. So that those 2 sessions might be interesting if you can get on, because they do some amazing stuff. I spent a couple of days with them, and it's amazing.
Cool. Well, anything else I can answer for folks?
One more quick little thing. Contraction. What's your experience with that?
I don't see. Well, define contracture, like German Shepherds with fibrotic myopathy.
Well, it could be from like a fracture, like an X6 situation.
Yeah.
X6. We did do some shock shockwave on it while it had the X-Fix on, and then after it got it removed. But what, do you have any experience with it?
I don't have a ton with that. Kirsty probably would, because she's seen all my weird cases for that. So that'll be a good one for her. But I think with those, what we've usually used has been much lower energy. Like
Okay.
contracture cases were like, can you come in 3 times a week and we're going to use like 0.2
Oh, okay.
and like really tweak them. Cindy, am I getting the right nod that I said the right thing? I feel like without checking with my text.
Yeah, it's usually on a RU or radius on the situation.
100%. So it's
Yeah.
treating more capsule, like stuff like post splint, post X-Fix, super
Okay.
low energy, because they've been in it for so long that if you try to undo it really quickly, I feel like it rebounds and it tightens up even more.
Oh, okay.
That's my thought. Cindy, what do you think?
Yeah, I mean, I think the big thing when people work on these starting or contracture situations is that you do need to keep on top of them a lot more often, even if it's not with the actual shockwave. But, you know, if the homework isn't done, it's useless, you know. So, you know, I have Dr. Struble uses it on a ton of contractures in San Francisco area. But, you know, if the owners don't go home and do the exercises, you might as well flush the money. So I think that's a big part of it. You know, you have to do it with the right owners. So.
Yeah. And that's why I think we've probably said, like, the more we can see them, it's not just to shockwave them with low energy. It's the fact of putting them in your hands, Kathy, to be like, and let me really do this work that the owners haven't been doing during the week.
Right.
There's the old chapters in the Millicent Levine textbook about responsive tissues to immobilization.
Yeah.
And remember that if X is the number of weeks it's been in a splint, 2 to 3X is going to be the time before they come back. And it's annoying. The owners are frustrated and the dog wants to run around 100%, but just go back to tissue dynamics. Set the calendars, set low expectations for each week, and just realize it's like a crock pot to undo those. If you rush them, all they do is just bound back up on you.
Okay.
And the owners have to get that. I know it's a giant pain, but set that and show it to them, and then you get success.
Thank you so much for your time, Matt. We appreciate it. And I think we all have some more things to think about and explore. And I appreciate everybody's time and energy. And then we'll send them out with next month's invite, so you guys can all have the information and listen to it again. And I know I learned something, so I hope everybody else did.
Yeah, thank you so much.
My
Great,
pleasure, everybody.
I gotta go.
Thanks again.
Good day. Thank you.
Thank you.
Bye.